All right. And our final presenter for this session in the morning is Kelli Blackwell, and is be speaking about antidepressant use and its influence on cosmetic surgery rates.
All right. Good morning, everyone. My name is Kelli Blackwell. I'm a third-year medical student from the University of Texas Medical Branch, all the way from Galveston, Texas. So I'm here today to talk to y'all about antidepressant use and its influence and relationship on subsequent cosmetic surgery in our patient population within a 5-year period. So major depressive disorder has, as of 2021, the prevalence in U.S. adults was 8.3%, and this number has been increasing throughout the years. And concurrently, the rates of cosmetic surgery are also increasing. So just between 2022 and 2023, the amount of procedures increased by 5%, totaling to over 1.5 million procedures. So the underlying motivations for getting cosmetic surgery vary from person to person, and the goal of aesthetic surgery is to address these patients' concerns about their appearance, and this can lead to significant improvements in their self-esteem, body, and overall quality of life, which in an ideal world, that is what would happen with all of our patients. But the objectification theory posits that women are typically acculturated by their society to internalize an observer's perspective as their primary view of their physical self. So the way they view themselves is based on how other people view them. And this can lead to increased self-objectification, body surveillance, and body shame. And this has been shown to increase rates of both acceptance and consideration of plastic surgery in these patients. Also, body dysmorphic disorder and depression often coexist. Studies have shown an increase of body dysmorphic disorder in patients seeking plastic surgery. For example, one study demonstrated the rate of body dysmorphic disorder was as high as 1 in 5 patients seeking rhinoplasty. And this has led to the idea of the, quote, problem patient. And these patients tend to be dissatisfied with their results, even if the desired aesthetic was achieved. And this can come in many types. And just to name a few, there's the patient with a minimal defect. So they, in their mind, this relates to body dysmorphic disorder. They have this defect that is much larger in their mind than it is to the outside observer. And there's also the polysurgical patient, the patient who keeps coming back for procedures. And the result of this is that these patients, after they get a cosmetic procedure, they may either shift their focus to another body part, or they're just going to be chronically unsatisfied with their result. And this leads them to seek further interventions with increased distress and ill feelings for both the patient and the practitioner. So the goal of this study was to investigate the association between depression, and we use antidepressant use as a marker for depression, and the subsequent rates of cosmetic surgery within a 5-year period. So we conducted a retrospective study using the Trinetics database, and this is a globally federated database of de-identified patient records. And from the start, there's about 117 million patients in this database. So we selected patients who have visited the emergency department within the last 5 years. And the reason we chose the emergency department is because it gives us a diverse random sample. And it also, when you go to the emergency department, they typically do a more thorough medication reconciliation. So this lowered the chances that a patient who is taking antidepressants may inadvertently end up in the wrong cohort. So we had our 2 cohorts. Our first cohort is patients who are on antidepressants, and our second cohort is patients who are not on antidepressants. And we propensity match these in a 1-to-1 ratio using age, sex, race, and ethnicity in order to control for any of these confounding variables. So following this propensity matching, we ended up with approximately 3 million patients in each cohort. And the outcomes we measured were various cosmetic surgeries such as breast augmentation, facial procedures, and trunk and extremity procedures. We also looked at other biopsychosocial effects such as alcohol abuse, substance abuse, and socioeconomic problems in the future. So when we ran our results, we separated our data points into males and females just to account for cosmetic surgery that is typically more gender specific, such as females are more likely to get a breast augmentation than men are. So for our results, females and males on antidepressants had a significantly higher likelihood of undergoing cosmetic procedures such as facial procedures and trunk and extremity procedures, and then specifically for the females, they had higher rates of undergoing breast augmentation. And additionally, for both males and females, they had a statistically significant higher rate of alcohol use, substance use, and socioeconomic problems within 5 years after starting antidepressants. And if you want to see the specific relative risks and p-values, they're all on this table. The top one is females and the bottom one is males. So, the effect of cosmetic surgery on psychological well-being is inconsistent. So some studies have shown that following cosmetic surgery, patients have decreased rates of depression and anxiety, but then other studies have shown no improvement or increased rates of depression and anxiety. And the post-operative psychiatric outcomes can be influenced by level of education, type of procedure, sex, and age. So there are many factors contributing, and it's not a one-size-fits-all. So, and one limitation of this study is that the Trinetics database is based on medical record charting. So it's using ICD-10 codes, CPT codes, and things like that. So this requires a documented diagnosis. So this doesn't account for the patients who have depression but are not diagnosed. And it's estimated in the population that of people who have depression, 40 to 50% of these remain undiagnosed. And additionally, some people with depression and anxiety choose to do non-pharmacological treatments. So these people may not be on antidepressants, but they may still have depression. Additionally, alcohol use and substance use and socioeconomic problems, these are very subjective and they have a very wide range of severity, and this may not be completely and appropriately captured by their subjective ICD-10 codes. And so the next steps of this project are to investigate if the patient's depression and anxiety do improve after surgery. So one way to look at that is how many patients got off their antidepressants following surgery, as well as exploring the underlying mechanisms and implications regarding this relationship. So the key takeaway for clinicians is the importance of preoperative psychiatric screening. This is crucial for identifying risk factors for post-op complications, dissatisfaction, and self-image issues. So surgeons should take a multidisciplinary approach using both their team and psychiatrists and psychologists to improve patient outcomes. And in the future, we need to work on establishing guidelines that physicians can follow in order to help create a better screening process to ensure both patient and practitioner satisfaction in the future. And these are my references. Thank you. So in private practice, so the question is, in private practice, how would you look for things like body dysmorphia and depression in your patient population? So private practice physicians still have access to all the same literature we do. If we were to create an established guideline that every surgeon could have access to, or maybe some standardized screening tools, that could really help them. And also understanding the underlying motivations for why their patient is getting plastic surgery. So it's not to say that if you have depression, you shouldn't get plastic surgery. It's a lot more nuanced than that. And I think it requires more investigation into the underlying motivations to understand like how the patient is going to adapt to changing a feature on their body. So based on the ICD-10 codes, we just use the major depressive disorder. So since we use antidepressants as our marker, it could encompass anyone with major depressive disorder, generalized anxiety disorder, and antidepressants have also been used to treat body dysmorphic disorder. So it kind of generally, even though we say antidepressants, it kind of generally encompasses a wide range of psychiatric issues that can be treated by these medications. Yes, I think so. So the question was looking at different antidepressants in terms of how they can relate to post-op satisfaction. So some studies, I think that would be very beneficial because some studies have shown with specifically SSRIs that there could be an increased risk of post-operative bleeding. And additionally, some side effects of antidepressants, depending on the antidepressant, you can have weight gain and some degree of mammoplasia. So it would be interesting to investigate whether if the weight gain and increased breast size in these women lead to more rates of breast reduction and what their outcomes are like. Thank you.
Please support our mission to improve quality of patient care through education. Join us, follow us, and share this content with family and friends.